First, I will like to tell you like few things about. So first, I would like to tell you few things about what is a pancreatic cancer and all. I will not focus much into pathophysiology because as a clinical pharmacologist, our main focus will be of management and monitoring ADRs and things like that. Though pathophysiology is important, but here in this case, as it was already diagnosed, the cancer and everything, so I would like to focus more on management side and monitoring things. Okay, so I'm sharing my screen. Pancreas. What is pancreas? It is one of the organ of our body. So it contains two type of things, exocrine and endocrine. So the cancer, whatever which will develop, that will be of either exocrine or endocrine carcinoma. Fine. The etiology of this cancer, it is firstly, as we know, for all the cancers, the etiology will be unknown. But the risk factors can be cigarette smoking, because the tobacco containing nitrosamine, mostly the nitrosamine of the tobacco is carcinogenic, so it can cause cancer. Second is diet, fatty diet and red meat या फिर meat containing diet. Third is partial gastrectomy. I know like these are the things which I have not included in the slides. So for like these things, you need to take a pen and a paper to note down these things. The risk factors can be cigarette smoking, diet, partial gastrectomy. Partial gastrectomy because in partial gastrectomy we have only the small portion of the stomach which can produce only limited amount of the acid, which can neutralize only like few like very small quantity of nitrogenous or nitrous compounds which are produced by the bacteria. So as I previously told, nitroso या फिर nitrate containing compounds are carcinogenic. Next is cholestokinins. These are the hormones which causes pancreatic cell growth. So this are also responsible because this can lead to excess, what we can say, uncontrolled cell growth. Next is diabetes mellitus because it causes insulin resistance. As we know, pancreas, the endocrine part of the pancreas is responsible for insulin production. Next is hereditary or familial history of pancreatic cancer. Next is caffeine and exposure to toxic substances. Okay, and metastasis. Panc Usually pancreatic cancer, this is mostly localized. In some cases, there are chances of metastasis, and the metastasis can be either to breast or lungs. Okay. Next is genetic mutations. So the genetic mutation can be KRAS or DNA mismatch repair protein. DNA mismatch repair protein is the protein wherever there is DNA mismatch, so it tries to correct it. So mutation in this thing, KRAS and tumor suppressor gene can lead to cancer. And one of the important, like for diagnosis purpose, in this case, we have like from CT, PET CT, and one of the tumor marker, that is CA19-9. This is the marker which helped us in diagnosing the pancreatic cancer. Management can be either surgery or chemotherapy and radiation therapy. Usually now like newer methods came in which is combined modality therapy. Are you aware of combined modality therapy? So in combined modality therapy, what we do is we combine chemotherapy with radiotherapy and surgery. So what we usually do is first we go with the surgery, then we give combined radiation therapy and chemotherapy. Okay, that is called combined modality therapy. So there was a study, RTOG study करके एक study था, in which we did surgery first and then we gave chemotherapy. Okay, one with gemcitabine and one with 5-fluorouracil to check which have better efficacy. So we have seen a better efficacy with 5-fluorouracil compared to gemcitabine. So can you tell me how many, like based on surgery, how many types of chemotherapies are there? Huh. So basically, they are based on surgery. If we see, there are two types of therapies. One is neoadjuvant therapy, and another is adjuvant therapy. So neoadjuvant therapy is the therapy which we give prior to surgery. Okay, chemotherapy which we give before surgery is called neoadjuvant therapy. So if we don't, like if we first do surgery and then we start chemotherapy, then that is adjuvant therapy. So in this case, we are giving a neoadjuvant therapy to our patient. So there are two types of neoadjuvant therapies. One is with FOLFIRINOX regimen, and another is with GEM plus nab-paclitaxel regimen. Okay. After 6 cycles or 4 cycles of this, we proceed with surgery, and we can do surgery like uh, based on prognostic factor, either resectable or non-resectable. Resectable is in the patients in which we can do surgery, and another is non-resectable. In this we cannot do, because if there is metastasis, then we cannot do surgery in these patients. Okay. So this was my patient. I can say this was my first patient. I did a complete follow up till surgery, because for surgery this patient left our hospital and went to some other oncosurgeon. So this was a 55-year-old male patient. The day which I took this case was his second cycle, but I did a follow up from cycle 1. So I took the second cycle because he developed ADR in this cycle with the chemotherapy. Okay. So what actually happened is, from the starting, I'll tell. This patient, initially he developed abdominal pain and discomfort. So he went to a local hospital. So that hospital did a CT scan which showed like something like a bulky pancreatic head. Okay. So they refer to higher, like we go to a local hospital. If they don't understand, then they refer to some higher organization. You might know about this, right? So the same way, this doctor referred to an oncologist. Okay. So the oncologist here, he suggested the patient to do PET-CT. So in PET-CT, they have seen necrotic soft tissue lesions in the head and usinate in process of the pancreas. So basically, this was a known, like this patient had a pancreatic head carcinoma. So pancreatic carcinoma happens in the head mostly, like 57% of the cases of pancreatic carcinoma is the head region of the pancreas. Okay. So, what we did was, when this patient was finally diagnosed with pancreatic cancer, the doctor, as the patient was 55 years old and he was not that healthy. He was not that muscular patient. So, you might not have heard about chemoport. You know about chemoport? How many access we have for intra IV drugs? How many access we have? If we want to give some IV medication intravenous, then how many access we have? One is peripheral and another is central. So we know only two. But we all do you know about PIC line? Peripherally inserted central cannula. It will be PIC line. So we usually give that in pediatrics. So in the same way, for onco patients, cancer patients, the patients for this patient, they have to every weekly. These patients have weekly or 3 weekly cycles. So for this patient, peripheral cannula will be painful, and central cannula we usually give in this large vessels. So that is very, what we say is prone for, that can be prone for infections, as these patients are already having low immunity. So giving a central cannula can be not a good option. And peripheral cannulation, that can be painful for every cycle. That's why for some chemotherapy patients who can afford it, like financially, and who are physically fit for this, for this patient, we near the heart, like in the chest area, we keep a small chemo port. So basically chemo port is like a small button like of thing which contains a vessel that is inserted in the chest area, which has a cannula, or what we can say, a catheter, that can be inside the body only, can be inserted in the large vessels directly into the heart. Are you understanding?
Yes.
So this procedure is not like this procedure is not a simple thing. It requires a surgery. So that's why for this patient, for his first cycle, we had a counseling for him and suggested him for chemo port. And for his first cycle only, under the general anesthesia, we placed a chemo port for this patient. So this port will be kept chest near his shoulder. It will be there. So every time we are giving, we will put a chemo port needle, and before and after in administering anything, we give a heparin flush. Why we give heparin flush? Any idea? Tell.
There is a blood thinner.
Yes, yes. So they as it chemo port is a vessel. So continuous blood flow there is a continuous blood flow in that vessel also. So there are chances ki they can be a blood coagulation. So for that, whenever we are using it, we'll give a heparin flush before and after the use. So this was about chemo port. You understood what is chemo port now?
Yes.
Huh.
Uh,
So for
actually, I've understood what is chemo, but just I didn't understood where it is. Means where it
huh.
is inserted, actual position.
As we have peripheral and central axis for IV, it's a basically b- peripheral vessel which have a central axis, central blood vessel axis with uh, what we say, a small vessel will be there. Okay, so after chemo port insertion, the next day, first cycle of Folfirinox was started. So uh, I will tell you why Folfirinox was started. There are only two regimens for pancreatic cancer. One is Folfirinox. Folfirinox is irinotecan, 5-fluorouracil, and what we have is leucovorin and oxaliplatin. Four drugs comes under Folfirinox. Whereas we also have another option, gemcitabine and nab-paclitaxel. For this patient, we are not using because there are two reasons. One is as I already told, ki in the clinical trials, RTOG, Folfirin 5-FU have shown better efficacy. 5-FU is 5-fluorouracil. It has shown better efficacy compared to gemcitabine. And also, when we give gemcitabine and nab-paclitaxel, it has a side effect. That is, it causes hypertension. So this, what you already can see in the medical history, the patient have hypertension. So nab-paclitaxel raises blood pressure by increasing peripheral resistance. Okay. So this is one of the reason we did not give nab-paclitaxel for this patient. Okay.
Okay.
So and so the patient here had no fresh complaints, but previously after cycle 1 he developed loose stools, 20 episodes per day, abdominal pain and discomfort. So this was actually a side effect of chemotherapy. I'll tell you how. So basically this patient had a medical history of hypertension and recently diagnosed CA pancreas. For hypertension he was on tablet telmisartan 40 mg OD, and the social history was nil. So the vitals were 145 by 80 Hg. Even the patient took in the morning his telmisartan medication, but when he came for cycle 2, he had higher blood pressure. The respiratory rate was normal, SpO2 was normal, everything was almost normal. Weight was 61 kgs, height was 166 centimeter, and BSA was 1.67 meters square. So why did I calculated BSA here? Because for all the chemo medications we give like whatever the drugs we are giving, every time we calculate weight, height, and based on BSA we calculate the drug dose and we administer it to the patient. So all the medications which goes based on BSA of the patient. And usually we have two formulas, like we have more than two, but mostly in our premises what we use is Dubois and Monstellar. But here for this patient I have used Monstellar for calculating BSA. So this was the patient when he came for cycle 2. This was the lab investigations. Him everything was normal, but his CA19, as I told, it is a marker for pancreatic cancer. This marker is basically present on cell surface of the pancreas. So whenever the pancreatic cells are getting uh, like from the surface, this is released basically. So whenever the like whenever like the higher levels of CA19 indicates that the pancreatic head is like the pancreatic cells are very active. So the cells can be active mostly in conditions. So this is the marker for pancreatic cancer, and it was very high. Usually it should be below 9 or 10 like that. So his LFT was normal. His blood CBP was also normal, and electrolytes were also normal. So the SOAP analysis. So the patient developed loose stools, though it was suppressed, but still it cannot be ignored. That too in a onco patients, because in onco patient even a slight increase in temperature, a slight decrease in temperature, any conditions cannot be ignored, because these patients are like very weak, they are not immunologically strong, so it cannot be ignored. That's why I have considered it. The patient had 20 episodes of loose stools and abdominal pain, but right now he came for cycle 2 Folfirinox. So objective evidence was BP was raised, CA19 was elevated, other things were normal. So as we already know, provisionally we thought that it can be due to AGE. AGE is acute gastroenteritis. So, but finally, we came to know that as the patient was he took chemotherapy for cycle 1, he cannot tolerated the dose. So that is the drug which have caused is irinotecan. So irinotecan has the tendency to cause delayed diarrhea. Diarrhea is of two types, acute and delayed. So acute can be like immediately which have occurred, whereas delayed is after 24 or 48 hours. So that's how the patient developed diarrhea after 48 hours because of irinotecan. It has a tendency to cause delayed diarrhea. Hypertension, that is like elevated BP was there. So this was the plan. So as we were giving Folfirinox, so because as he developed the diarrhea because of the regimen, we have changed the dose of Folfirinox, which we call modified Folfirinox. So can you tell me what are the drugs that are included in Folfirinox? Hello, am I audible? Anyone? Hello.
Yes, you are audible.
So what are the drugs that are included in Folfirinox? Oxaliplatin, leucovorin, irinotecan, 5-FU.
I
Can you tell me? Can you tell me why we are giving leucovorin? What is leucovorin? And when we give leucovorin? Okay, first I'll tell
Sorry, no.
oxaliplatin. It's okay. Oxaliplatin. So the usual normal dose for oxaliplatin is 85 mg per meter square. Okay, and leucovorin is the actual dose of leucovorin is 400 mg per meter square. But in cycle 1, as we cannot give directly the higher doses, we give 240 mg per meter square in cycle 1. So that was around 250 or 300 the dose was. So We for the modified Folfirinox, we have changed the dose of leucovorin to 50 mg. That is, we did not calculated anything based on BSA. We gave a constant, like a solid dose of 50 mg leucovorin. Next was irinotecan. Irinotecan is 120 we gave previously for cycle 1 we gave 180 mg per meter square. That's the standard. But in modified Folfirinox, we gave 120 mg per meter square. 5-FU, that is 5-fluorouracil. We did not change the dose of 5-fluorouracil because it should be given as 2400 mg per meter square. It should go in 48 hours. 5-FU should go for 48 hours. So we cannot keep the patient in the hospital for 48 hours for the drug to go. So for this thing, we have a extra, what we say, elastomeric pump. So what that pump does is we just fill the medication and the diluent in that pump. It slowly releases the drug for 48 hours. Okay. So this elastomeric pumps are available in two. These are available only in two brands. One is Baxter pump and another is Dosifusor. So for this Baxter pump, we have 48 hours, whereas for Dosifusor, we have for 1 day. Okay, this Baxter pump, it releases constant 5 ml per hour of the drug, whatever the total along with the diluent we are putting. So in 5 ml per hour, it releases. Okay, whereas elastomeric, another one that is Dosifusor, it releases per day के हिसाब से it releases 250 or 240 ml of the content per day. So for this patient, we are giving a neoadjuvant therapy because after 6 cycles we have planned for surgery. So right now the patient have completed his 6 cycles and he has gone for surgery. So basically we are giving this patient a whipping procedure. Whipping procedure is pancreoduodenal resection. So this was the drug chart. So can you tell me what is olanzapine? You might be wondering why olanzapine I have written indication as antiemetic, and also for dexamethasone why I have written it as an antiemetic bulk. Aren't you? What's olanzapine?
as antiemetic for
Antipsychotic.
related.
Yeah. Sorry.
Antipsychotic.
Sorry, I cannot hear.
Antipsychotic.
Antipsychotic, but it has tendency, like it have the antiemetic effect also. So we have learned in toxicology in some have like diazepam and all that can be used as antiemetics karke if you remember. The same way we are having olanzapine and dexamethasone, they have unknown antiemitic effect. So for antiemetics we have actually different regimens. What is the major side effect of chemotherapy drugs? Major, one of the major,
Nausea, vomiting.
nausea and vomiting. Very good. So for this nausea and vomiting, we have we have classified chemotherapy drugs based on the tendency of nausea and vomiting. The tendency of causing nausea and vomiting is called emetogenesis. So based on the emetogenesis, we have classified the drugs into three categories: highly emetogenic, moderate emetogenic, and low emetogenic. Okay, so usually platins and higher doses of cyclophosphamide, it comes under highly emetogenic, and in moderate we have doxorubicin and lower doses of what is this cyclophosphamide and ifosfamide and all drugs comes under moderate emetogenic, whereas in low emetogenic we have this thing, uh, pemetrexate, we give methotrexate also, that it comes under uh, low emetogenic drugs. So here we have platins and platin analogs. platins, cisplatin, and platin analogs are carboplatin and oxaliplatin. So this comes under highly emetogenic. So for highly emetogenic, we have 3 drug regimen, 3 drug antiemetic regimen, 4 drug antiemetic regimen, like that. So here we are using 3 drug. Usually there's a 4 drug antiemetic regimen because we are having olanzapine, nicron, and dexamethasone. Nicron is, did you have ever heard apripitant, netopitant? Do you know
Yes.
ondansetron? You know
Yes.
ondansetron?
Yes.
You know palnestron? Palnestron.
Heard somewhere.
Huh. So basically, nicron, it is a combination of netopitant and palinestron. Netopitant is 300 mg and palinestron is 0.25 mg. This is the oral tablet. If we are giving palinestron IV, then the dose will be 0.25 mg. Okay. So nicron have two anti-emetic drugs, olanzapine and dexamethasone. Using palinestron, and why not ondansetron? Because ondansetron can only suppress acute vomiting episodes, whereas because of its shorter T half, whereas palestron, it has 24 hours action. That's why like it can even have an action on delayed vomiting episodes. Dexamethasone, it has anti-emetic action, as well as it like its presence have shown a better efficacy for chemotherapy drugs, like better action. So oxaliplatin, 85 mg per meter square, when we have calculated, we got approximate 140 mg dose. So oxaliplatin, one vial will be of 100 mg. We don't get the exact doses of the chemotherapy drug. So whatever dose we get from that, we have to calculate and we have to take it from the container. So and some of the drugs are like what we say, they are powdered form drugs. For example, cyclophosphamide. It is a crystal, like it's a powder, but when we try to reconstitute it forms a crystal, and that crystals float on the surface. And nab-paclitaxel. Nab-paclitaxel is a nano albumin bond paclitaxel. So the paclitaxel is binded to the albumin, nano particles of albumin, in order to show a better efficacy. So as it's an albumin when it's shaken, it forms bubbles, it forms foam. So this is available in powdered form. So we should know how to reconstitute. Like being a clinical pharmacist, it's the job of a clinical pharmacist to know which chemotherapy drug should be diluted, reconstitute in what diluent or what fluid. So oxaliplatin, it comes in 100 mg vial. So I want 140 mg. So I have taken 2 vials. So this comes like pre-reconstituted. So 140 and 100 mg in 20 ml fluid. It comes like that. So from one vial I have taken complete 20 ml, and from another one I have taken 8 ml. So that's how I have reconstituted oxaliplatin. So it was diluted in dextrose. I have Here I have written. So oxaliplatin was diluted in 500 ml, 5% dextrose. We cannot give chemotherapy drugs directly. We have, because they are. I will further say there are 2 types of chemotherapy drugs based on either they can cause extravasation or irritation. That's why we give in a diluent. So oxaliplatin, it's a vesicant. It causes extravasation. That's why we are giving it in like more. What is the major ADR of cisplatin? Major thing that it causes? Can anyone tell me? It causes AKI. It causes tubular necrosis. So in order to avoid that, we give excess fluid. We give more hydration to the patient to avoid AKI. So the platinum analogs, they are modified and they have less chances of causing AKI. That's why we choose them. Okay. So oxaliplatin, it was diluted in 500 ml, 5% dextrose. So did you understand why we are giving it in dextrose?
Yes.
Hello. Ha. Next is irinotecan, 120 mg per meter square. So the dose which we got was 200 mg. Okay. So this 200 mg we are giving in 250 ml NS over 90 minutes. Oxaliplatin we are giving over 2 hours. We cannot give it fast. So we are giving it slowly for 2 hours. Irinotecan we are giving for 90 minutes. So irinotecan, if we are giving, like if we have diluted it, we cannot store it for longer hours, because if we want to store it for longer hours, then we have to dilute it in dextrose. So as we are using it immediately, we are diluting it in NS. Leucovorin directly 50 mg, we are diluting it in 250 ml NS and giving over 1 hour. So what this leucovorin does is, usually we give these things with antimetabolites. So here 5-fluorouracil we are giving to 2400 mg. The dose which we got was 3500 mg. So this we are putting in Baxter pump. So each vial contains 50 ml. So 7 vials I took. Sorry, each vial contains 10 ml. 10 ml containing 500 mg of 5-FU. So that's how I took 7 vials containing 70 ml, containing 3500 mg of the drug. So I've put that in the first, I've filled in the Baxter pump this 70 ml. Then later on, the remaining 240, the total volume of the Baxter pump should be 240 ml in order to get 5 ml per hour for 48 hours. So we should know all these calculations as a clinical pharmacologist, because the doctor he asks us to fill the pump to calculate everything. We should do this. So 240 ml should be the volume of the pump in order to release in 48 hours 5 ml per, the constant will be 5 ml per hour. We want it over 48 hours. So we have to decide how much volume of the we are making in the Baxter pump. So based on that, I have decided that 240 ml should go into the pump overall volume. So in this 240 ml, 70 ml was the drug. So remaining, how much is remaining from 240? I have put 70 ml. What is the remaining content? What will be remaining? How much will be remaining? 170 will be remaining. From 240 ml we want to put. So from that 70 ml the drug I have put, 70 ml drug. Remaining is 170 ml. So 170 ml NS I have put in the Baxter pump. So the overall volume was 240 ml. In 240 ml, 170 ml was the NS, and the remaining 70 ml was the drug, which was 3500 mg of 5-FU. So this pump is now 240 ml. It will release constant at a constant rate of 5 ml per hour over 48 hours. Okay. So leucovorin, here it comes leucovorin. We give it before 5-FU because it helps in receptor binding of 5-FU. Okay. And also it accelerates the action of irinotecan. That's why, as we already got the ADR of irinotecan, so we reduce the dose of leucovorin also, because even 5-FU have the tendency to cause diarrhea. So this was about the drugs. Did you understand why and how we are giving the drugs?
Yes.
So next is discharge medication. So this is very important, because in the hospital, whatever the thing is there, we can do, and after that, everything depends on the patient what he has to do. The only thing we can do is to suggest him this you have to do at your home. बोल के. Further, it's his choice how he follows. So discharge medication is olanzapine 5 mg once daily at bedtime. We are giving it bedtime because it's an antipsychotic, like antipsychotic. So tendency it will cause drowsiness to the patient. Next is and DSR. pantoprazole plus domperidone, one tablet, we suggested him to take twice daily because he had like previously also he had a history of diarrhea and abdominal pain. So that's why we suggested him BD twice daily dose for 3 days. Next is as he had his BP was still high even after taking his regular medication, telmisartan 40 mg OD. So we thought of adding another drug that is Metexel, metoprolol. So we have reduced the dose of Telma to 20 mg at for night. As he was taking in the day, we suggested him to take telmisartan at night, and we suggested him to take Metexel 25 mg in the morning, daytime. Okay. Next, syrup mucin gel. So, mucin gel is basically an antacid substance, but in chemo patient, one of the major side effects is it causes oral ulcers. The drugs causes oral ulcers. So, mucin gel is also used for oral ulcers. I'll tell you how a syrup is used for oral ulcers. And what, as a clinical pharmacist, this is a counseling point. You have to tell the patient about how to take this drug. So further is in case of loose stools, we have suggested him that whenever he experience loose stools to take Imodium. What is Imodium? It's low pyramid, 2 mg immediately after loose stools, and it should be taken every 4 hours until the loose stool subside. Next is Taxim O. Taxim O is an antibiotic. It has shown unknown there were studies in which it has shown an unknown what we say unknown effect only on diarrhea. Though it's an antibiotic, it has. I counsel them that they should hold the medication for 15 minutes in their mouth because the whatever the antacid or whatever the cooling property it has, it will show on the mouth protective effect, and then after 15 minutes it should be swallowed. And we have 5FU. So 5FU is it has the tendency of causing photosensitivity to the patient. You know what is photosensitivity? There are two types of
Sensitivity to light.
photosensitivities. There are two types of photosensitivity. One, that is the photosensitivity that is for the drug, and another is for the patient. Like when we are giving a medication, either the drug is photosensitive or after administering the patient gets photosensitivity. So 5FU, it causes photosensitivity to the patient. So we have counseled about that to the patient and asked him to avoid sun for this 48 hours. And the patient was explained about the diarrhea and how he was because of the drug and the he couldn't tolerate the higher doses, that's why he experienced the diarrhea. And he was counseled about the we have added Metexel, and we have changed the dose of Telma. And next as this Sulfurinox is a 3 weekly regimen, we advise the patient to come after 3 weeks for further another cycle T. So this is a role of pharmacist. First is clinical pharmacist interventions. So what I did as a clinical pharmacist in this identifying the delayed diarrhea of irinotecan and calculated dosage of works regimen for this patient. And as the BP was very high, so immediately we administered Stamlo. Stamlo is amlodipine. So for immediate action on the BP, for if the patient don't want IV, they want oral medication. So for hypertensive urgencies, we usually in IV we usually prefer labetalol, but for oral we prefer TCB with an ARB. So as the patient have already taken an ARB, that is telmisartan, we gave him an amlodipine, calcium channel blocker, 5 mg, a start dose. You know what is a start dose? Okay, start dose is the first initial dose. After that, it's like if it's still needed, we will continue, or else if it's not needed, we won't give the drug further. So next was irinotecan. This the drug is photosensitive. So what we does is if whenever a drug is photosensitive, we after diluting it, we wrap it in an aluminium foil or silver colored foil, and for that we give. There are many types of photosensitive drugs. Uh, they can be sensitive to this visible light or UV light or sunlight. Okay, so based on that, we decide what kind of covering or protection the drug needs. So irinotecan, this was sensitive even to the our normal light. So that's why I suggested like the doctor that we will wrap this drug in an aluminum foil and we will administer. So he agreed. So role of CP in this case. So what I did as a CP in this case was medication reconciliation, that I took past previous medical history of the patient, that is reconciliation, patient counseling about the condition and the drugs and the ADR which happened, dose adjustment based on ADR of the drug, dose calculations for modified fulferinox regimen, and chemotherapy drug dilution. So in chemo sector, or what we say in chemo department, a CP plays a very important role, a clinical pharmacist, because the drug correct dilution, calculation, and administration and monitoring, it is completely a CP's role. So, as a CP, chemotherapy drug dilution I did, and I made sure that the correct drug and the correct flow rate the drug is being administered, and I monitored for further if there are any adverse events or anything, and that's it. Done. Thank you. Okay. Anyone? So this was the case. Hope you learned something new from this.
Actually, learn many new things.
Thank you. So, uh, ha, one more thing is, one more new thing I would just like to tell is, uh, uh, so we give nab-paclitaxel and gemcitabine for do you know hand foot syndrome? Actually, I have learned recently this news from a new study. That's why hand foot syndrome is usually like few chemotherapy drugs. They causes hand and foot the skin peels off and only the sole and palms are affected. The skin peels off and they get irritation. Like it's a kind what we say rashes and everything occur on the palms and sole. So to avoid this, what we give to the patient is emollients. So the cabecitabine, doxorubicin, and gemcitabine also have the tendency to cause this. So in a recent study, after seeing that, I was shocked. Diclofenac, it's an anesthetic that is used as for hand foot syndrome. Like the skin gets peel off. Diclofenac, it have it can cause burning sensation, but still it was used because it was showing an anti-inflammatory and emollient effect.
As a painkiller, it can be used in such
Y-
conditions because if the skin is
yes,
peeling off, then the pain receptors will
inflammation.
be open.
Yeah, yeah. So for that ADR we were using. So apart from folfirinox, we also have gemcitabine and nab-paclitaxel, as I told you. For gemcitabine, the dose will be 100 mg per meter square, whereas for nab-paclitaxel, it will be 100 mg per meter square. Uh, Sorry, for gemcitabine, 1000 mg per meter square. For nab-paclitaxel, 100 mg per meter square. And this both can be diluted in the first choice of diluent is NS, and it can even be diluted in dextrose or DNS. So apart from this, supportive care what we can give is if the patient is having malabsorption, we give megestrol acetate supplements. This increases appetite. So we give 100 mg per day. Next is if the patient is having a loss of exocrine function, we give pancreatic enzymes. And usually when there is metastasis, there are chances of ascites. So for ascites, we give diuretics, and usually we put a drain. We put a drain for ascites. So and for every chemo patient, we suggest them for high protein diet. And there are few drugs based that causes myelosuppression. You know myelosuppression?
Yes, bone marrow suppression.
Yes. So it depends. Like depends on the drug. There are few drugs. If they causes if they causes myelosuppression greater than 60%, then in that cases we give pegstim or filgrastim. It's a stimulant, CSF factor and all stimulant. So filgrastim we give. We also have a module like filgrastim. This have a shorter half life. So we have pegylated uh, forms of filgrastim that is called pextim. So this have longer half life because of pegylation. It have a longer half life. So that's so if the myelosuppression is greater than like if we have the drug causes myelosuppression, then we give this on the after 24 hours of the chemotherapy. So as of now, the patient's CBP was normal. We did not give any of this pegistim or filgrastim. If the patient's CBP would have been abnormal, then after 24 hours, we would have either given filgrastim 300 mcg or pegistim. Okay.